come through. And that was from, hang on a second. I just, there's someone else coming in. If someone can let them in. Right, so we have apologies from Onyeka, who'll be coming in and out, Ruth Hamilton, Mervyn Thomas for today. And also we've had a separate email from Marcus Nystrom, who said they won't be able to be involved in this great initiative. So I believe we should take that as they're leaving the group. So I will, that was just to update everyone. Now, if we go back to the agenda, the next thing up was, did everyone review the minutes? And was there any comments or corrections for that? Doesn't look like it. I did get a comment from Amanda. Are you on the call?
Yes, hi. Sorry, I'm on my phone because we're on holiday.
I mean, I can read it out. I think you were the only one who actually commented on the terms of reference.
Sorry.
Because it was after the meeting took place. But I don't know if you'd like to kind of bring up your point now. I think one of them was the membership. I think we didn't mean to leave out optometry, but we can add optometry as membership of the subgroup.
That'd be great. Thanks.
And I think your second comment was about members being appointed based on expertise, geographical representation, and commitment to the subgroup objectives. So I think you're asking about specific criteria?
Yeah, I guess the question is, do we have specific criteria to that? Because that is quite broad, right? Is it just, hey, is it going to be people that are appointed because they're experts in this area? Do we want to make sure that we've got representation across? I guess I was thinking representation aspects the same way that we did with the survey, and making sure we've got all of the appropriate subgroups to it. So just kind of touching on that point and thinking about it and going, is there anything that we should be, in the same way that we thought manufacturers, should we be thinking about anything else being appointed to? That was all I was sort of thinking there.
Yeah, so I think when the group was originally set up, it was deliberately broad. It was not meant to exclude anyone. And I guess that's why that was written quite loosely. And I guess we can keep coming back to it and revising it, because as we proceed through the exercise, we're probably going to find actually it would be useful to have someone with this or someone from this area included. It could be something that we continually review and evolve. Don't know if anyone else has any thoughts about that.
I think that's a good way to deal with it. I just didn't want it to kind of drop off and be this thing of, it is broad, and I get that it's broad on purpose, but I guess I was trying to be even broader and trying to think in that space, but totally fine with where it's at. Just wanted it to be something that we kind of raise.
Okay, Matt has a comment.
Yeah, I'll just add that this is because this is the very first standard that we're developing, which is why it's such a broad group. The expectation is that in the future they will be much more smaller focus groups, but because this has so many underpinning potential aspects to it, we just need to get everyone on board, really.
Okay. If there are no other comments, what I might do is just put a little note in each agenda that we just a quick check of the membership, and if we need to reach out or change the membership at any point. And that way we'll have that constant reminder at each meeting. And that should cover that. Yes, Fiona?
Yeah, thanks. I think that most of the standardizing bodies that are out there have like basic specifications for the makeup of a committee that include like having a minimum number of nationalities represented and so on. So it might be worth maybe reviewing those and aiming for something similar. It is possible that, you have a standardizing body already in mind that would be most appropriate, but in general, I think it could be good to, review those and be compliant with the sorts of specifications that are out there.
Okay. So do we want to
I think we
maybe...
are also, sorry, I think we are compliant, but just it could be good to formalize it a little.
All right. Well, here's where I go. Do we have 1 or 2 volunteers that actually want to take that as an action? Just to review what's out there. And
I can add that.
jumped
I can
up.
add that to the general meeting for the next proper ISCET meeting. We have got very loosely. We've said we wanted to make sure that a committee included clinicians, particularly as the chair. We had to make sure it had multiple nationalities represented, different research groups, and so on. But it isn't codified in any kind of formal way. So I think if I add that as a point for discussion at the main ISCET meeting, we can then make sure that we cover that, particularly when we go to smaller groups in the future.
Right. Now I'm just going to move on to just a quick reminder of what we're intending to do. And then we're going to devote a lot of time to the outcome of the exercise that was carried out. So basically, at the end of the last meeting, it was decided that we would attempt to draft a fixation protocol for clinical use, and to be written in such a way that it's accessible by non-expert clinicians, allied health professionals, but that it would be of a minimum, as well as giving out what the gold standard would be for what the minimum acceptable standard would be for clinical use. And we got the ISCET style headings from Ruth to try and model our development on the ISCET guidelines, and some responses from that. And Rebecca had the delightful task of trying to collate all that and kind of get a feeling for how well this went, or what we might need to do to refine the process. So it was an interesting exercise. So what I'll do is I'll stop sharing, because there is an Excel sheet which I did attach to the meeting invite, but I'll let Rebecca talk to it because I think she found it interesting.
Yeah. Okay. So I collated everybody's responses, and then what I tried to do was remove anything that was duplicate, which left us with certain points for each section. And I just thought it'd be easy just to go through each point and see whether we thought it was relevant or irrelevant, or if there's anything else that needed to be added in. So I've not put my opinion in there. I've been completely unbiased, and I've just left it so it's everybody else's thought. So shall I just share that Excel sheet?
Yeah.
It's probably the easiest thing to do. So can everybody see that?
Yes.
Yeah.
You might have
Okay,
to
so
I don't know what other people can see. I can actually put it out on a separate screen, but I don't know if everyone else can blow up their
Bigger?
individual ones.
Bigger?
Yeah.
Yeah.
Can everyone read that? Yeah, Matt's nodding. So
Yeah. Yeah. Okay. Right. So obviously we had the headings, and then I left in the examples just in case we needed to go back to those at all today. So the first heading was introduction, and I could see that had been quite clearly split into what people thought was the brief overview of the test, and then what the purpose of the standard would be. So some of that, just to say as well, some of those responses were very detailed, and some of the responses were just sort of points that we might be able to expand on. So first of all, in terms of the overview, there were a couple of points made. So we can see there that eye tracking provides an objective, quantitative assessment of eye movements during fixation, allowing precise characterization of fixation stability and abnormalities stroke clinical relevance. And then measure distribution of fixation and eye movements, so the shape and the spread. And then consciously choosing to focus at one point or during a fixation task. So this was a bit different. This was added detail, I felt. And then another point was to say to determine whether these lie within normal limits, and then what we should do if there are pathological eye movements detected. So further analysis is done depending on the type of eye movement detected. So I don't know if anyone's got anything to add in there. I mean, I can add I can add bits, and I don't know, I'm not sure what we think is the best way to move forward with this. Do we
we have
discuss
one?
each point and see whether it's relevant?
Like, do people have a feeling on whether one of those statements more or less captures all of that? Because what we want to try and do is agree on one definition or description.
So I think this point here is a very good starting point. So eye tracking
Yeah.
provides an objective, quantitative assessment of eye movements during fixation, allowing for precise characterization of fixation stability and abnormalities and/or clinical relevance. But do we want to add anything else into
Well, maybe
that?
that third point down explains fixation more more simply. Although I think anyone attempting to do a fixation protocol must have at least some concept of what fixation is.
Well, I would think so. I would think
Yeah.
so. Does anybody else have any feelings?
Arthur?
Yeah, I remain a little puzzled. I think we discussed this before, and I don't want to beat a dead horse, but the guideline for eye tracking in nystagmus is one concept, and fixation is another concept. And so I am a little confused whether this is a guideline for fixation or it's a guideline for eye tracking in nystagmus, because nystagmus does not require fixation, can have fixation. You can have nystagmus with fixation. You can have nystagmus with no fixation. So, so are we just removing the whole concept of eye movement abnormalities, nystagmus, that is not dependent on fixation? That's not part of this guideline.
Okay. Sorry, Larry's hand went up as well. Is that related to Arthur's point before we start? Larry?
Pretty much. I just finished writing a lecture where I dealt on fixational eye movements, and that to me usually means things like microsaccades and tremor and the other really miniature eye movements. But as Arthur just said, that nystagmus may change with fixation effort, but it's present with, without it. So I think fixational eye movements, especially shape and spread, which implies looking at, was it the BCEA, whatever the it's too late at night here for me, where you compute the scatter of the miniature eye movements, which isn't something we really do with looking at nystagmus. So I think that box in C11 really doesn't fit nystagmus.
Yes. So just to be clear, we're writing the fixation independent of nystagmus, but parts of it will be relevant to nystagmus. Oh, Frank?
Okay. Can be. Yeah.
Do you see what I mean? Because what we're trying to do is when we write fixation, because this is in line with the rest of the work of not just this subgroup alone, but it could be something that the other subcommittees will be utilizing, and not necessarily for nystagmus, but we may be specifying parts of this for use in nystagmus where relevant.
Okay, that makes sense. Yeah, because there's certainly other eye movements, like the various saccadic oscillations that occur during fixation. So
the idea of this
as
is
long as
it's a standard for anyone who's trying to adopt eye tracking in clinical use.
Okay.
And they need to look at fixation for whatever reason. Yeah. For whatever reason, they need to do fixation just as a guide to the basics of how to do it, how to get started on it.
Yeah, I don't want to start a semantic argument.
Yeah. So, I mean, see, that was what was agreed at the end of the last meeting. Otherwise, we were running around in circles.
Yeah.
Like, do we start with nystagmus? Do we start with fixation? Do we start with a system?
Yeah. fixations is good as,
Yeah.
I have no objections to starting with fixation.
Sorry, I'm just trying to stop that phone ringing. Yeah.
So
Yes,
can you hear me, Helena?
Yes, yeah.
Yeah, so I mean, a question of whether this is semantics or not is the issue. I suppose it's about using language that people recognize as much as anything. So if we just added precise characterization of nystagmus, comma, fixation stability, and abnormalities, does that just give a bit of clarity? Do we want to say eye movements during attempted fixation? Would that help as well? Some of this depends upon, and maybe we need to see what's above here. What are we aiming for here? In previous standards, how big is this little section here? We don't want it to be too long, do we? I think when looking at what was there before, this is just a short little summary, is it? Is that the idea here? Rebecca might be able to answer.
Yeah, Rebecca, do you want to go back up to see what ISCET did?
Yeah, so here we've got, so their examples, so they've split here into multifocal ERG and ERG. So for ERG, for example, mass responsive retina flashes of light, 6 ERGs.
Okay, so it needs to be really brief by the sounds of it, yeah?
Yeah, but I think, Frank, just taking it back, you've used the word nystagmus again, and I think, Matt, can Matt just clarify again?
Yeah, so I recognise the awkwardness of this because we've obviously come together as an nystagmus committee, and I do believe that we will be looking at nystagmus in more detail slightly later on in the process. But basically, this needs to fit into a library of standards. And for example, if you're doing a saccade testing paradigm, that implicitly requires you to do multiple fixations. And so we're starting with this bare bones, very straightforward protocol of what is a fixation, what kind of target do you use, and so on. That we can then build upon that later on and say, if you're doing this in the context of nystagmus, let's say you run the protocol and you find, your BCEA, for example, shows that it looks like there's nystagmus, then you would have these additional things you might do in that context. You might do the fixation target at different positions to check for a null zone, for example. So right now, just the fixation, but that doesn't mean we're not going to then provide some kind of guidance on how that would be applied in nystagmus later on, but just to make sure that this can stand alone and be used in all other situations. Does that make sense?
Yeah, so basically, it can. If I were a clinician in a clinic and I go, they have some sort of eye movement disorder. Well, I'm not, I can't tell what it is.
Start with this.
You want to know, yes, what do I need to do on this basic fixation to help me with that question and what I do next? Amanda?
So I guess coming back to this and coming back to the fact that words like nystagmus and fixation are bringing in and triggering other aspects to this, could we keep the intro brief by sort of combining that first one, which I like the detail of it. It's specific. It's if we scroll, eye tracking provides an objective, quantitative, but then they also attempting. So I think adding the word attempting to consciously choose to fixate at one point, I think that would articulate what we're asking people to do, what the point of the task is, recognizing that not everyone's going to be able to do that, but then not coming back to that word nystagmus, not coming back to the issue of when we talk about fixation line movements, all the other little pieces underneath. So I'm putting it out there to the group. Could we kind of combine those two and have that be the intro?
I think that's a very good idea, but it might be nice to get a feel for the rest of the group. And we can all obviously email that out to everyone else who couldn't be in the meeting to see what their feeling was or is on that before we settle on it.
So I'm adding it in, and I'll highlight it. Yeah.
So to attempting to and combining it with the way the first point defines fixation.
Do we agree that this measure of fixation and eye movement shape and spread, as Larry, just going back to Larry's point, I get what Larry's saying there. When we're thinking of drift, tremor, we might be looking at this in a bit more microsaccades.
Spreads.
So it could also be worth including velocity. Shape is rather spatial. It
is. Does anyone clinically look at velocity for nystagmus? I guess I'm not quite sure where that comes in before we've started quantifying things.
So I actually wonder if that's more in the clinical protocol, you know, further along when we get, there's a section where we actually specifically say, I think this section needs to be quite general.
Yeah, I'd keep velocity for later.
Yeah. Gemma?
Yeah, I agree. I think things like numbers, velocity, all of that is probably more relevant to the analysis / interpretation, which is in column K. So I think the detail of that comes later by this spreadsheet.
Okay.
I think that's
Arthur?
also, sorry.
Okay. Yeah, Arthur, and then Fiona.
I will stop talking, but I do believe, in my personal opinion, there is a setup for your experiment for recording, which includes fixation, the disease, everything that requires you to cause the eye movements that you're trying to measure. Then there is, separate from that, is the method, how you're going to measure and produce some data that measures that eye movement in that setup. And then third, consistent with what Helena was saying, there is the analysis part. What do you do with the data? I do believe all those three things are very separate and each have humongous range. And thus, I remain uncomfortable with combining the eye tracking in nystagmus concept with fixation or with analysis. Those are kind of separate. And so one can argue fixation is a whole guideline all on its own. And that eye tracking in nystagmus is a guideline all on its own. And the analysis is yet another thing. So those are, I feel like it's three things. And I think what if I understand it correctly, what you're suggesting is to give people a general, very limited idea of a fixation setup, which will 100% will not apply to anybody I see. Some general idea of eye movement recording and some general idea of analysis. So if that is the aim, then we should admit to that all of those are going to be incomplete, very far from complete. That's at least how I see it.
Okay. Thank you for that, Arthur. Matt, you want to come in on that?
Only in so much as the the completeness, I think, will come with, you're right that a protocol for fixation on its own you can't apply a complete protocol for fixation in and expect it to cover all the different use cases. So I think the protocol for actually having somebody collect the data is one thing, as you say, that is a separate issue. And I just think it's going to be a modular thing. It's going to be a modular thing. So you'll have the stimulus type, that can be something we record here as a particular protocol, but then that stimulus will be applied in slightly different ways depending on whether you're looking at, for example, fixation of eye movements, by which we mean microsaccade and so on, or nystagmus. So we're not looking to write a single document that will provide everything you need to know in one go. It's going to be modules that you kind of pick a protocol from here, you then apply it in this situation for this patient and so on. So no individual document's going to be complete. It's going to be bits and pieces that we have to put the puzzle together. Sorry, that wasn't very helpful. But that's what,
it is basically starting with one piece of the puzzle and then going on to finding the next piece of the puzzle and then starting to add them all together. And it was always going to be difficult to do this first guideline protocol, whatever we're going to call this standard. A lot of those points actually come up later in the columns. There are things, condition, child, a lot of this comes up in the Excel sheet. So we'll just take 2 more points on that, and then we actually need to move on to some of the next columns. So we've got Fiona, then Larry, and then we'll move on to the next column.
Okay, thanks. So I can very much agree that these are really separate things. And I think that, you know, navigating how to separate them out is what these discussions are really essential for, because we can navigate them as we like. In terms of velocity, I'm pretty agnostic as to whether it comes here or later, but just to frame it, I was more thinking about very general things like, you know, fast and slow wave of nystagmus, for example, which I think, you know, is still pretty high level. So yeah, but I'm learning as we go and listening to you, like, as I'm sure everyone is, how to separate it out. I don't really have any idea of what that should be, but I think it's maybe general enough just to consider fast and slow beats in nystagmus at this state level.
Okay. Okay, so Gemma's putting in lots of things in the chat, but Larry, do you want to talk, and then we'll look at what Gemma's saying in the chat,
Okay,
and then
sure.
we'll move on to the next
Sure.
column?
Just briefly, I don't think we want to be too specific at this point. I think if we're examining someone with an eye movement recording, we're almost certainly going to be asking them to look at something, unless we're recording in the total darkness. So I don't think I'd want to get fixated on the fixation task, but I would say just basically classifying what you see when they are fixating would be the starting point. That may then branch off to nystagmus. It might branch off to a saccadic oscillation, or it could include the classical fixational eye movements that's been mentioned before. But I would keep anything that sounds like analysis out from this stage. And that, yeah. I will stop.
And I think no, Larry, that's very sensible. You should really join us late at night more often. That's quite pragmatic. That's what the clinicians will want. Yeah.
I'll try.
I mean, if we look at the spreadsheet, it becomes more detailed as we move forward. This is just an overview, is my, you know, looking at what is specified up here. Brief overview of the test and the purpose of the standard. I don't think we need any, my personal opinion is that this doesn't need to be detailed at all, because that detail, if we just come over here,
it comes up next,
comes here in the clinical protocol. And that's where people have mentioned things like positioning, head stabilization, room lighting, task instructions. And then we also do go on, just to give just for anybody that's perhaps not looked at the spreadsheet, where what we do for pediatric recordings maybe, and then also, I'm struggling to maneuver this along, everybody's in my way. And then analysis, you know, this is where the detail comes in, I think. Matt, is that's the feeling?
Yeah, I think, and I think this is where we might want a separation. So having the protocol, I think we can. I think from what I'm hearing is there's agreement that, you know, you're going to have a single protocol for fixation. It's basically draw a dot of some kind on a screen, and so we can hopefully, you know, package that up as this is the protocol, and then the way in which you analyze it, and also the way in which you deploy that dot, you know, where the range of positions will depend on the condition. So I think we might need to separate analysis from protocol, the test protocol, and that might allow us to get some slightly more sensible way of thinking about this that can be applied in multiple situations. And there's not a lot to say about fixation really, other than put a dot on a screen. It's just how long and where.
And size, and, you know, how ideally you should do it if you can. Okay. Shall we move on, Rebecca?
I'm going to move back across. So we're still on the same, still on the first. So brief overview of the test, and then maybe if I just move down to the purpose. So we've got points. The guideline will provide practitioners with information to facilitate conformity and allow cross-evaluation between labs. These are all very similar, actually. Offer recommendations on minimal requirements for calibration, data acquisition and quality criteria. Establish standardized definitions. And then, yeah, facilitate broader use of eye tracking in clinical practice, which is probably actually quite relevant for the, that's what we want to do. We want to encourage it, don't we? Yeah, supporting diagnosis in several indications, and then provide understanding of visual experience, identify CPAN.
So what do people scroll up and show what ISCET did with some of theirs?
So what? So this is still the same point. So this is, look,
okay.
very,
right,
very, yeah.
Yeah. So we're using a lot more detail than ISCET is, aren't we?
I suppose that, yeah. Any comments? I mean, my feeling is that these points, there or thereabouts, are kind of all saying the same thing.
Yeah. Might be just worth merging those somehow, capturing all that information into a single statement.
Yeah. See, I could have done that. Definition. I could have done that. Yeah. But what I didn't want people to think was that I had any bias. I wanted everybody to see everything, and
what we could do is when we do the minutes, we can put all those points together, and then if you want to try and put it into a single statement, then we can send that out to the broader group and go, is everyone happy with this suggestion for a definition, this suggestion for the purpose?
Yeah.
Sound fair? Yeah.
Yeah. Happy to do that. So
it's transparent, so everyone can see. Fatima.
Yeah, I just want to say, because I do electrodiagnostics. Eye movements are way more complex than ERGs, ISCET ERGs, because they're essentially quite black and white, whereas like eye movements are not. So that's probably why we have so much more to say than the ISCET standards.
Yeah.
But so anyway, we shouldn't be so I think Fatima, are you saying then we shouldn't be concerned that we've got more detail, that there's or more words, should I say?
Well,
you don't think?
I think we probably could do with more detail, but for the first bit at least, I'd imagine it should be quite succinct. The introduction, I've sort of lost track of it, sorry, because I've been in clinic. But
we're on the definition and background bit of it, so we're on the column 1. Larry?
Yeah, I mean, yes. I don't know really. I think detail is good, as eye movements are so complex. That's what I'm trying to get at. But whether it's going to help people, I'm not sure.
Okay,
Larry, go ahead.
How about something like to detect the presence of an ocular oscillation, and through further examination, identify its nature? And then that can branch out into different kinds of nystagmus, saccadic oscillations, but is a general purpose. It's first, is there an oscillation? And if so, what is it?
That's good.
It's nice and general.
You do function well late at night.
The children of the night. Yes.
Say that again, Larry. What did you say?
To detect the presence of an ocular oscillation, and if present, to identify its nature, e.g. saccadic oscillation, nystagmus, either
etc. Not excluding anything.
Acquired. Yeah, I think that's enough.
Can I just say, can we add instability? Maybe it's not an oscillation as such, but an ocular oscillation or instability would give it a little bit of, make it a little bit wider, wouldn't it?
Yeah, you'd pick up like the roving eye movements of the blind or something. Or I'm forgetting the other. It is
I just
late
think
at
the
night.
square wave jerks and things probably, but thanks,
Okay.
Larry.
Okay, yeah, you're right. It's not always an oscillation. Yeah, instability is good.
Tim.
Okay, we're getting somewhere.
Right. Next section. So summary of changes is not applicable. Yay.
Yeah, yet.
And then physiological origins. So there were no comments here really, apart from somebody had mentioned oculomotor control sensors, microsaccades, drifts, tremors. I mean, so it does say at the top there that in terms of the description that sometimes this is part of the introduction.
Yeah. Gemma?
When someone finds out, can they let the rest of us know as well? We'd be very interested.
Well, it looks like Gemma's smiling, so I assume she's going to give us a beautiful lecture on physiological origins of fixation.
I was just going to say, I'm happy with what's suggested, but should we include in there, like, vision? Because whilst it's not a physiological origin of it, it will affect it. Level of vision.
Valid point.
So I guess I'm saying an ocular pathology, I guess, or lack of.
Do we want to include
integrity.
physiological origins?
Well, yeah, that would be my question.
I feel like we've had lengthy discussions on this in the past, and I mean certainly with nystagmus, is it genetic? Is it retinal? What do you mean by origins? And I think it's quite a complicated story, isn't it? That's the issue here.
Yeah, because I don't think it's completely agreed.
Maybe we should.
Omar, your hand went up quite quickly.
Yeah. Maybe we should stick to Fatima's point as well, as if this is genuinely more complicated, we don't have to adopt everything that ISCET have done.
So maybe we'll keep that as optional. We might come back to this if we find that we do need to put more detailed explanation as to physiological origins.
Yeah, I don't think we're going to find the neuron for nystagmus.
Matt?
Yeah, I'm basically agreeing with this, that we don't know in the same level of detail that, for example, we understand what mediates an ERG, so we don't have to shoehorn everything into the exact same structure that's used by ISEV. I would imagine that when we come to writing, for example, the smooth pursuit protocols and saccades, we would have, in the introduction of the standard, we would write a little bit about it. And some stuff is known about fixation, but of course the pathologies we're looking at aren't necessarily the same as the thing that mediates fixational eye movements. So it might just be for fixation. It's a bit of an odd one. There's so many possibilities. We just have a brief paragraph on what is known and leave it at that.
Okay. Right. Omar, your hand went up, and then down. Are you okay?
Yeah, well, hi, I'm Omar Marous. I'm Director of Standards at ISEV, and I had to join late because of another meeting, sorry. And I know you're running late, so I don't want to delay things too much. But just from the ISEV point of view, obviously don't feel any obligation to use the ISEV format, because it may well not be suitable for this. Probably isn't, might not even be suitable for ISEV, to be honest. But one thing is, we often start with guidelines where there isn't a standard and kind of summarize the evidence. I don't know whether you'd already considered whether you want to just make this a kind of general guideline, and you'll see the headings are slightly different on your guidelines tab than the standard, and all of this is kind of optional, so some of it won't be appropriate, and the ISEV standards are very much just describing this is the test and maybe some example use cases, but not really giving you everything that you can get from it or what the diagnosis is going to be. So it doesn't have to be, exactly as ISEV do it. And whether you want to start with a guideline, since there isn't an agreed standard of practice here, and the guidelines often kind of summarizing the evidence base for different techniques. Anyway, that's all I wanted to say, but you may well have said that already before I joined.
No, that's fair. I think we're just learning as we go along what's working, which is why we started with the ISCET standard. This could be a guideline. It might end up being something else, but we'll see. And Matt?
Yeah, just to fill in on guidelines versus standards, at least what ISCET has agreed so far is that it would simply be a name change. The first published standard of any of ISCETs would be called a guideline, and then the only thing that would change is that when that was revised, because that would give people time to see how it fits, it would then change to a standard. I don't think there was any decision to change the content in any way. It was just more of a semantic adjustment once it had been road tested for a while.
Okay. I think what we're taking from that is we may not necessarily need to put in physiological origins, but when we do write the introduction, we might be able to do a brief paragraph without opening up Pandora's box of where nystagmus originates or something like that. Right. Rebecca, do you want to take it from there?
Yeah, shall we move on to clinical applications?
Yeah, hopefully this one's easier.
So we've got a few points. So nystagmus or any suspected disorders of fixation, assess duration and accuracy of fixation in certain conditions, and then the conditions are specified there. Highlight changes in fixation pathway, assessment of fixation stability and fixation related eye movement abnormalities, including nystagmus, saccadic intrusions, macrosaccadic oscillations, ocular flutter. And then somebody made a point that maybe it should be, for both central and peripheral neurological disorders affecting ocular motor control. And then, so it was kind of split into two things. So it was like a general kind of which conditions, if you like, and then people moved on to subject stroke populations as well. So we've got old adults and older adults, pediatric populations, and healthy controls.
Okay. Arthur's hand went up.
I would add treatment effects in outcomes of clinical trials, outcomes of interventions as an important clinical application.
So I'm looking at this going, could we just basically create a list of where we think doing a basic fixation will help you diagnose, detect, or measure an ocular oscillation or instability, whatever we're deciding on in the introduction.
So I've got to say, before I started bringing everything together, as the responses came in, I didn't look at them, and I actually thought it would be a list of points rather than lots of information. As a starting point, a list of points that would then be padded out as we went through, which is almost easier, isn't it? If you've got a list, in my mind anyway, to sort of move forward from a list of things. Gemma?
Yeah, I'm, I guess, less of a fan of saying that everything is a disorder of fixation, because clinically you might have normal fixation, but you've taken something, it might be an effect of a medication that affects their fixation. So rather than calling everything a disorder, I would say I would clinically do this where I either wanted to confirm stable fixation, investigate unstable fixation, or nystagmus, because it doesn't have to be that they have a disorder of fixation. Something is just affecting their fixation stability. That could be a disorder, or it could be a side effect of a medication. So I think not going down the road of everything's a disorder, I would clinically apply this task to a patient where I either wanted to confirm their fixation was stable or not, or investigate the possibility of unstable fixation or nystagmus.
Gosh, I can't spell.
It's being recorded, so.
Do you know, but this is just show you how much I rely on predictive text. You know, when I'm writing, I probably write a complete load of rubbish in the normal way.
Oh gosh, okay.
So-
Someone's joining. Yeah, go ahead. I missed a bit of it because my internet dropped out, but I assume Gemma's come up with a beautiful way of sorting out this column.
So I'm saying investigate the possibility of, and say, I know it's being recorded, but I just want to try and get as much down as possible. Gemma?
Yeah, I was going down the lines of stable or unstable fixation.
Investigate the possibility of stable, straight, unstable fixation. Is that enough?
Yeah, I'm sure it could be tidied up. It's not
Yeah.
necessarily the most
But
succinct.
let me
but
just pop it in.
I
I'll
guess
pop it
my
in for
point was
now.
it doesn't have to be a disorder of fixation for fixation to be unstable.
Yeah,
It could be a side effect of something.
yeah, okay. And got another hand up.
Fiona, was it?
Sorry, it's me. Hi. I might have missed this, but are we just talking about primary position fixation? Or are we going to talk about fixation in different positions of gaze? Because obviously that's another whole issue, isn't it?
Yeah, Matt, are you responding to that?
Yeah, sorry, that was just a response. This doesn't specify the position in which it's shown, and I think the condition being investigated would dictate where you actually place those fixation targets. So agnostic.
I think some of that details also come in the clinical protocol.
In the next, I think,
Yeah,
next column,
I think.
or that the next one's how we measure, and then there is a protocol column.
I mean, one of the things I was thinking was if somebody has saccaded initiation failure, and so then to be able to create a fixation in, say, lateral gaze, they're going to be moving their head, etc., etc. So that's what I was thinking about. That's all. But you're right. I suppose we can discuss all that, or can be described later on.
Yeah, and that will come up later on, I think, as part of protocols and adjustments that may need to be made for different conditions that are suspected or identified. Yeah, I mean, we won't.
And obviously there's
nothing.
the children with head posture, nystagmus and head posture. So that's going to be
Matt.
I'm just checking. Fiona's had her hand up for a while. Is that?
Oh, sorry.
Yeah. For us?
Thanks. I was just wondering if retinal health might be included in the list of potential causes of nystagmus, since central vision loss can sometimes cause nystagmus.
Yeah, I think for the purpose of fixation protocol, we're not getting down into the detail of causes of nystagmus, because that would be a whole separate.
Well, just below where you talk about the different underlying disorders in this column.
In here, Fiona.
No, I think it was further down. Yeah, where you have this neurodegenerative diseases, Parkinson's syndromes, so on.
Right.
There's nothing in this column referring to retinal health issues. So I'm just suggesting maybe that could be considered.
So my question would be here whether we actually need all that detail. It would just be,
because either we include a complete list where this might be applied, or we have a general kind of definition that can be applied to everything where it would be affected.
Yeah, I think like one or the other is fine.
Yeah.
But if you're giving these examples, then you know, the retinal health is quite a different category of issues.
Yeah. I guess you can put that in there, Rebecca, just so we have a track of everything's been discussed, regardless of what we decide in the end. So we'll give those two options out afterwards. We can go for a general definition, or we can try and create a full list.
Matt?
Yeah, this is just following up again on what Fatima was saying and thinking about how you apply it. I posted a message on the forum a while back suggesting like a layered approach to this. So you'd have essentially the core fixation protocol, which is agnostic as to how many points you show and where you show them and so on. And then that can stand alone, and potentially that could then feed into, for example, the basic saccade protocol, because those are just a series of fixations. But then we can have a layer above that where we say, if you're looking at it in this condition, this would be a protocol, you know, for nystagmus, you test at this many positions along the horizontal axis, for example. So I'm wondering if that might allow us to think more cleanly about separating these things out. So the analysis side of this would basically not be present for the core protocol. The core protocol is just the method of delivering a fixation target. And then we can then think about different disorders later on as a layer above that. Just a suggestion.
Okay.
Yeah, so I think at the minute what I've done is I've just taken what everybody said, and they're just in the columns. It doesn't necessarily mean that that's what we're going to end up with in terms of a list of diseases, and yeah, that's the way that this is, just everything just all pulled together. Should I just move on to, because we're like almost an hour in now, shall I move on to the next section?
Yeah, but I guess we'll get back some time from where we don't actually have to get into analysis if we go with what Matt's suggesting.
So here we've got the technology,
how it's carried out, isn't it? Or is it technology? Yeah.
So it's technology next. So describes the hardware, software, and disposables needed to acquire patient data. So again, most people were on the same track here. So eye tracker with minimal specs, acquisition frequency, accuracy, calibration, and then we've got a bit more specifics, any eye tracker, and then the detail in there, and then we've had the screen mentioned with enough detail to provide the stimulus. Somebody's mentioned head stabilization, software firmware calibration. And then somebody also mentioned stimulus parameters, duration of fixation, size, but I felt I've put that in the red there. I think that's probably more clinical protocol.
I'd agree with that.
Yeah.
So I guess one of the points in there was interesting because it said needs to be evidence-based. So do we have an evidence base to kind of base the minimum requirements to detect pathological EMs anywhere?
So I'll throw that to Matt.
Yeah.
So all right, yeah, that was my cell that I filled in there because I was doing it off the top of my head. So I'm sure it's out there, and I'm sure somebody in this group probably knows the answer to that. I can't remember off the top of my head. But these were the specs that I would expect an eye tracker to have if I was going to look for pathological eye movements.
Oh,
but as I said, I didn't go into literature. Maybe Larry knows.
Yeah.
Speaking as the dinosaur in the room, a lot of work on the nystagmus was done with fairly low spec eye trackers. I certainly think, the old Olympus trackers, and even some with EOG, but 120 hertz gives you 120 hertz is, I assume that's frame rate, which gives you 60 hertz bandwidth, which is plenty to resolve almost any nystagmus. The only things you might miss would be very fine details of saccades or very miniature eye movements. But the specifications for most of what I do are met by any eye tracker I can think of. We might want to actually say with a fixed frame rate, because some of the head-mounted eye trackers, the spectacle types, have variable frame rates. And that would be disastrous for this. But I think that other than that, I think those specs are more than enough, but I would say fixed frame rate.
Fixed frame.
There's a lot of hands going
Rate.
up.
Sorry, Larry, I can't hear you. Fixed frame.
Rate.
Right.
Okay. Right.
Rate.
got-
Sorry.
Yeah.
RATE.
Oh, I rate.
Yeah.
Okay,
2
sorry,
words.
I couldn't. Yeah, sorry, I couldn't hear.
Apologies.
No. I think there was a bit of talking going on. I think Arta.
I think the frame rate is very much dependent on the abnormality. If you're looking at wandering eye movements then you don't need 120 hertz. If you're looking at very fine fixational abnormalities, then obviously you do. So it would depend on the disease condition and the abnormality is what I would suggest.
Well, that's what I said, but I think for almost any except the miniature eye movements, 120 would suffice. There was a resolution there, wasn't there? 1/4 of a degree in the box above.
Yeah, I'm moving.
Yeah.
Yeah, I did pull that
There
out
it
the
is.
air though. So just
Yeah.
to be clear,
I was suggesting they're too fine.
For some things. Well,
absolutely.
okay.
Right.
It'd be an area I've never worked in, so I acknowledge if you're looking at microseconds, then you definitely need a higher frame rate. It has to do with the duration of the eye movement.
Yeah, Amanda's had her hand up for a little bit, and then Fiona.
I'll put mine down.
I think it's jumping on and probably expanding on Arthur's point there, but if we're making this a generic fixation standard, maybe it comes down to being different levels for different conditions. And I think rather than being really specific and saying, 120 hertz is a minimum here and specifying exact numbers, I think this needs to be a lot more generic because I think it is really going to vary a lot depending on exactly what you're looking at. And thinking about, if somebody's using a fixation standard here, but they're looking at tiny movements and using a retinal tracker, for example, that might be really, really different to what we're thinking about with congenital nystagmus patients. Just wanting the group to kind of take that step back and think about the fixation specific element of this, I guess. And I realize that Larry has touched on some of those, but I guess what I'm trying to add to this is making this column generic.
Mm-hmm.
Just
okay.
thought.
And then Fiona?
Yeah, just in terms of the minimum spec that's quoted, I mean, there is quite a lot of work on, what frame rate or sample rate is required and, how different kinds of eye movements are bandwidth limited. And I think Wirtz way back in the 80s probably went right down to 50 hertz for reconstruction of fixations. But I don't know if you want to state something here or just cite someone like Wirtz and what he says about bandwidth limit of eye movements. For sure, fixational eye movements, microsaccades, drift and different things require different sample rates. And it's, I think, another way of saying stability, sampling stability is often referred to just as temporal precision. And that's just as important as the spatial precision for looking at anything velocity-based like nystagmus. But I think there needs to be a clear line, obviously, between how much you want to go into that versus just cite someone like Wirtz or the existing work on this. And I'd be happy to, share some literature reviews on that if it's useful.
Yeah, I was going to say that I think it sounds like we've got a little piece of work to do outside of this meeting where we pulled together the evidence and the literature that already exists on this very question, and then take that into account when we're completing this general definition or overview of requirements for this fixation protocol. Does that make sense? So that at least it's based on as much evidence as possible.
Yeah,
Matt?
just to say that there is a lot of evidence already
yeah.
existing that maybe it's better to just cite.
Yeah. So do we have volunteers to pull that evidence together ahead of the next meeting that we can distribute, so that we don't have to keep running around in circles during a meeting? We can actually have a chance to review it and then agree this point in the next meeting.
Did Larry put his hand up then?
Oh, is it Larry?
Well, I've just been looking at some of this and doing. I foolishly accepted the opportunity to do 4 3-hour lectures for Hong Kong Polytechnic. So I was looking at some of this. Is what essentially a table of what kind of specs you need to look at what kind of eye movements? In other words,
Larry, if you've got that, and if Fiona could share what she's got literature-wise as well, and if we can combine that.
Maybe if she could send me what she's got, and I could look at what I have. Could you maybe just email that to me? Because I've been looking at some of this.
It's that this is probably my main contribution can be around this topic, because this is also a big topic for me. So, but I don't think I have your email address. If you wanted to send it in the chat, I'll be happy to link in on this.
I'll do that. Right. I'll just put it up there. Where am I?
Matt,
Matt?
Yeah, I was going to say that I feel like specifying these cutoffs is kind of the main bread and butter of what my vision of what ISCET is there to do, is to make sure that there are clear criteria for, and of course they can vary by condition and so on. But I think that it would be remiss of us to simply say, yeah, you should consider this, because that's what we're trying to specify, so that everyone's actually doing things in the same way. And also I would say that it's not just the frame rate of the eye tracker. There's actually, when we get into the methods, there's going to be numerous things. What diameter of target should you use, and how you scale that for VA, and when we come to other things like smooth pursuit, what's the optimum velocity and so on. So I think maybe from this meeting we can just get a list of the parameters that need to be considered, and each one of those points we need to go to the literature and pull out an evidence-based decision. And if there is no evidence, we can come to a consensus on what we think is roughly what we're all doing. But I think there's going to be more than just this one parameter, so maybe we should get to the end, list those parameters, and then we can all go away and come up with, maybe we can do that as a group, what would you use, and do you have evidence for that?
Yeah, that sounds quite sensible. Okay,
move us across.
Carry on, Rebecca.
So now it's clinical protocol. So this is describes the process.
We're over time now, so I just want to check, do people want to stay on to continue? Because we're on to the guidelines, so I think we do need to get some of the basic agreement on what we need to measure, and then we can get into the evidence for it afterwards. Okay,
so we've got patient positioning, again in quite some detail. So I think this was just you, Matt.
It was, again, this is not meant to be, this is how everyone should do it. I thought the task here was say what you do at the moment. So I'm completely agnostic as to what methods, sizes, steps and so on we use, but I was simply saying this is what we do in our lab. It's all up for debate, but these are the points that we use.
So we've got patient positioning, and then we've got head stabilization, room lighting. We've to talk about the task instructions. Sorry. So we've got a 1 degree diameter. This is the target, I think, Matt. Yeah. This is where we're talking targets.
Yeah, that's the one we use. It's just a bullseye that's been.
And then people have just said timings, recordings, whether it's binocular, whether we use a visual correction or not. And I think these are all valid points. Room lighting, effect on pupils, duration, data quality check, data interpretation. Now, I don't know if this kind of moves more into the analysis side of things.
Yeah, I think so.
That's analysis, I think. Yeah.
And then somebody had also suggested that we give out example traces for different fixation abnormalities. but again, maybe that fits more into the analysis. This is more you do this, 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 and this, isn't it? I think.
Yeah.
So
I
does
guess if
anybody
we can
have
get an idea of
Yeah.
have we got everything that we need to do? Like, are we missing anything for a standard? I need to check fixation. Trying to be agnostic to particular conditions, but we've got one eye, both eyes, correction, without correction, as well as the target,
timing,
light,
room lighting, again, duration, head stabilization.
or
Patients.
well, do you necessarily for the pediatrics you've got to be a little more flexible with that, don't you?
Yeah.
Yeah.
Yes. Infants.
Yeah. And I think that comes into the next bracket, pediatric recordings.
Yeah. So
and everybody
to
was
have
kind
that.
of on board there. Yeah. You know, I think general differences apply. Cartoons, rewards, eye tracker, you know, maybe you'd use a remote system.
Okay, so no one seems to be jumping up and down about anything that's particularly missing from that list. So what I'd suggest we do is we send out that
the list. Yeah, I agree.
See if anything needs to be added. Yeah.
If we bear in mind as well, not everybody responded. And I think it would this now we've got this list, it's probably easier, it's a starting point, isn't it? And it's easier for people to add or comment. Now we have a list.
Yeah.
And with that, we could ask for, do you have an evidence-based or do you know literature or something for each of these? It'd be nice to have the corresponding evidence base.
Yeah. So I think when it comes to the pediatric population, I mean, there were only a couple of comments, and I think potentially because we all know, probably because we're kind of thinking what we do in terms of making those changes if we have a child in. But again, list, if we send this out and anybody can add to anything that they think might be useful here. And again, any evidence.
That makes sense.
Okay, next is artifacts. So blinks, saccades, and then just a comment on artifacts removed processing steps.
Yeah.
Not described here as a general method to be defined in a separate ISCET protocol. Is that you, Matt?
Again,
like
sorry, that
was I wasn't sure then.
I figured that's going to be, it's going to apply to whether you're doing pursuit or saccades and so on. I don't think we would need to describe these differently for fixation, unless I'm missing something important.
Okay. I think that's a good point to stop, Rebecca.
Yeah, we stop him.
Yeah, the next one is we're getting into analysis, aren't we?
Yeah, we are. And I'm thinking maybe that's just a step too far at the minute.
Yeah. We actually need to decide what we're doing first before we analyze it.
Yeah.
To be honest,
that's the whole meeting.
Just in case you don't go back to artifacts, you might want to put thresholding artifacts in there. They're really important in certain forms of nystagmus, aren't they? If the thresholding is wrong, you can get all kinds of so-called fixational instabilities that don't exist because your thresholds are all over the place.
Okay, good point.
Thanks.
No, this is a good exercise. I think we're making progress.
Sorry.
Matt?
Can I check thresholds for what? Sorry, what kind of thresholds are we talking about?
Yeah, so what I'm talking about is if for pupil tracking, if you're, we see it a lot in albinism. If the thresholds are not right, it just flickers on and off.
Oh yeah.
It looks like fixation instability, but it's flicking on and off.
Okay, so of the eye tracker, the luminance threshold.
Yeah, exactly. The luminance threshold. Yeah.
Okay.
Right.
Yeah. So, and then as it's analysis, but my feeling is it's probably a bit of a step too far to go to. I think, to be honest, I think probably this section here on the clinical protocol is probably the easiest to start with, because everybody here would have an idea of what they do, and if there's any evidence for that.
Agree.
So I wonder, so do we send, as I say, that not everybody responded, and I had less responses than I thought that we would have. So it might be really useful now if people look at this and add to or comment on.
Yeah, I'd agree with that, because we need to get this. There's a lot of people not in this meeting now that need to be feeding back and commenting as well, and we've got quite a few action points anyway.
So should we make this sort of an online document that people can dip in and out of?
Okay.
Would that, rather than, sending it across to one person? Not that I mind. I'm happy to do that again, but it would probably be easier just to make it like a Google document, wouldn't it? Or
we can try. Yeah, I think what we need to do is consolidate the discussions so that people are catching up on the discussions that they weren't in the meeting, so that they can see why we've ended up doing it this way and know why they're adding to it. Does that make sense? And then we can say, complete it online here.
Would it be worth pulling out the things which we decided are out of scope at this point in time, and then maybe highlighting to people, because I think the thing which we're going to need a lot more discussion on is the specifics, the size of the target and so on. I guess we haven't really got to that point today, but we want to know that's what we want to get some ideas of.
Yeah, I'll make sure that when we do the minutes that we have a big bold, what we have decided today is out of scope, following discussion is, and then we'll just say, and it might come back into discussions later, but for the moment, these things are out of scope. Yeah.
I'm going to stop sharing.
Yeah.
I just wanted to say, I think it would be a lot easier to contribute like links to literature and so on as well if there was an online document, because then we can put them in where they're relevant rather than just sending a big long list. For me, it's always much easier if there's a document of some sort that where we can have commenting and putting in some content.
Set that up in that workspace that Matt already has set up for us, haven't you? Where we're sharing
Yes,
things.
although
can we do
Fiona
it
had some
there,
ideas.
We've
been Fiona and I have been chatting through within another subcommittee about if there are better ways than Google Docs for being able to actually evidence the paper trail of all the changes and so on. Google Docs, you have anonymous contributors, and there's things like. Do you have anything to suggest, Fiona, for this?
Well, I mean, we talked about using Overleaf, but that's LaTeX based, and that's not always very popular with everyone, although it's come a long way in terms of the online interface being very similar to Word if you want it to be. You can have different views, but I think, whatever works for most people is the most important, because if we put any barriers, then we're less likely to get contribution, I think.
Can Word work as a track changes in a Dropbox or something?
Or even Teams, potentially.
Yeah, maybe in the Teams channel, it tracks, doesn't it?
To a degree, but it's a lot of work to go back and see who said what and who contributed what, unless you have someone actively maintaining that. Whereas something like Overleaf, it's trivial because it does all that for you, and you just go into history. Or any Git repo where also, you can do a blame-based thing. The reason is because often when you get to standardization stage, they want to see evidence of the committee agreeing and reaching consensus, and apart from just attribution, that's also important. But I don't have a perfect solution, because the things that function better are often require a little bit more technical, a higher technical comfort level with some technical stuff. If I was to suggest anything, it would be Overleaf, just because it does allow you have different views. But I really think the most important thing is whatever people will actually use.
what's the learning curve? I've never heard of it, so what's the learning curve for it?
Well, I've used it with people who have never used it before or anything like it. So I have used it successfully with clinicians. It's not that you need to be like a techie to use it anymore, but at the same time, that's really hard to say. Something like Google Docs just is okay as a temporary fix, but it probably wouldn't be great in the long run.
You could look at it does maintain versioning, doesn't it?
You can see changes when you log in, but unless the person explicitly selects a certain mode, the changes are not attributed in the text.
Okay. Yeah, that's a problem.
I think actually, if you go, there is a version history in Google, but you don't get the suggested mode. That you can go into suggestions mode. It might be that if we are going to continue using Google Docs, then we could just explicitly say we want you to log in, so we can actually see what contributions are from each person.
I always do.
That's not perfect, but it's at least a step in that direction towards attribution rather.
Okay. Rebecca and I shall contemplate how we create a shared document that's trackable then.
Okay.
Whatever way it works.
If it's helpful, I can try and find a few things to look into and send them a few options. But maybe for the moment, Google Docs is okay.
Yeah.
Okay.
And I might play around with Teams and my OneDrive and see if external institutions, because I know when I use OneDrive Word internally, certainly I get a good track changes going on.
Yeah. I wonder if we can use that extra. Like, I was thinking that actually, and Frank would probably.
Well, I could set up one and see if you can do anything to it in Cardiff and Leicester.
You back, Frank?
No, just a random document.
No, Frank might know. I'm just thinking, Frank. OneDrive.
Yeah. If you share a document in OneDrive.
Can you do that between institutions?
Have anyone
I'm not
tried
sure
that?
about that. Most of the time we've done it, it's within the university. I don't know.
Yeah.
I've done it successfully before, but it really depends on the university's privacy settings. And what you're allowed to do.
Yeah.
All right.
Well, I can try that, and one of our universities might allow it.
Okay.
So, Helena, shall we convene at some point then?
Yeah.
You and I. Okay.
Can I suggest for future meetings, should we maybe be worth getting like a rolling meeting in the diary, because otherwise it takes a long time to poll everybody for when we can next meet and so on. We say for the clinicians' benefit to give at least a month's notice, but if we can give a month's notice for a kind of like maybe every 2 weeks we would meet for the time being, it might help to keep things going. Unless that seems too often, I don't know.
So you'd like us to meet every 2 weeks, Matt?
if that's too often, that's fine. But
but I can't actually fix a time like that because my diary looks horrendous. So we're always trying to find.
Carry on as that's fine.
Is there a meeting scheduled upcoming after this already?
No, because we're going to see, because I did think we'd end up with a lot of actions and we were going to have to give people time offline to deal with them before we have a meeting. So we're going to have to take that into account.
Yeah, just have some idea of when to try and prepare some of the relevant literature and so on. But I'm guessing you're saying that if you agree to it, there should be a month's notice, then there's at least a month, right?
Yeah, and possibly if you need more time to actually put together the literature, then that's what we need to do. Because we need to do what's necessary to make this work.
Right. Well, we'll see how it goes, but I will get on the task with Larry.
Yeah.
Oh,
we should let Larry go to bed.
Oh, Larry. Okay. All right then. Okay. Thank you, people.
Thank you, everyone.
Thanks. Good to see you.
Bye.
Bye-bye.
Bye, everyone.